next panel is Compassion and the Patient Experience, and Monica Worline will be moderating this panel. Again, thank you so much. I hope you enjoyed lunch.
Welcome back from lunch. I always think it's a mark of a successful conference or meeting when you can't tear people away from their conversations to come back to the program. So I hope you're enjoying the day as much as I am. There is empathy built into this panel before we even start, because if you think about the title, the patient experience, built into the title is a form of perspective taking, right? Putting ourselves into the shoes of the patient, and we have 4 extraordinary speakers to help us put ourselves into the shoes of patients. The first, Robin Youngson, has many accomplishments which you can read about in his formal biography in your program. What I want to mention in particular is that he uses my favorite word. I'm an organizational psychologist, and I've been doing field work, field research in technology organizations, and I've started using the word rehumanizing work. And without even asking me, Robin used that word to talk about rehumanizing healthcare. So thank you for being here.
So I stand here with a feeling of just really profound gratitude. I first began my career speaking internationally on compassionate healthcare in 2006, 8 years ago. And at that time, I did a Google search for the words compassion and healthcare, and I could not find any document in the world on Google that had those 2 words together. And here we are at this wonderful conference, hearing inspiring speakers, and this is a movement now alive and well. So I really want to thank all our dear friends at CCARE, Dignity Health, at the Charter for Compassion, who have sponsored and hosted us and looked after us so well, and just a great sense of gratitude. I want to talk about happiness in healthcare, and I swear to you that I did not write my presentation at lunchtime, but it's going to pull together everything that you've heard this morning in the most wonderful way. And I want to make clear, if some people have trouble with the word happiness, I'm not talking about that in the hedonistic sense. I'm talking about the joyful life in service of others, as His Holiness would talk about. I was called to be a physician, that calling of compassion, because I knew suffering. And my assumption was that it was disease and illness that caused suffering, and my job as a physician was to treat and cure and fix illness and injury and alleviate suffering. And over a long lifetime of working, I've come to understand that that is a fundamental mistake, and that is not my true role as a physician. And as I've come to understand, is that my true role is to bring my compassion in response to the suffering of patients, because suffering itself is far more the cause of disease than disease is a cause of suffering. And that's been a really fundamental change for me. And sometimes we discover truths that are so simple and so profound, it can take us a lifetime to understand them. Here's some evidence in support of that assertion. This is a study of 1,000 Dutch seniors who'd survived a heart attack. They were followed up for 15 years. In the course of cardiac rehabilitation, they did a psychological profiling to find out who among them were the optimists and who were the pessimists. The pessimists had 4 times the mortality rate over the next 15 years compared to optimists for cardiac causes of death. And for all causes of death, it was 3 times higher. Turns out medical students will do anything if you pay them enough money. In this study, the medical students, I kid you not, agreed to be inoculated with influenza virus into their nose and throat, every one of them. And they did the same kind of psychological profiling, 3 equal-sized groups, the optimists, the middle group, the pessimists, and almost all of the pessimists got flu, and almost none of the optimists, and the odds ratio was 3-to-1. This is a remarkable effect. This morning we heard some of the mechanisms that might underlie that. Burnout is very prevalent among health professionals. This was a study in Israel of 8,000 employees in their 20s, 30s, 40s, 50s, and 60s, not frail elderly people at all. And a few have more than the threshold score on Christina Maslach's burnout inventory, you have a 40% increased risk of having a heart attack or a stroke. That's a bigger risk factor than smoking or high cholesterol and not exercising, and yet it doesn't appear within the risk factors that we pay attention to. If you have extreme burnout, it's an 80% increase in risk. There's extraordinary studies coming up now showing how our life conditions and suffering change our gene expression. This was a study of patients who were abused as children. As the result of that suffering, they turned off the gene that's required to create a very essential protein called brain-derived neurotrophic factor. This is required to allow your brain to grow in a normal structural way. These patients have borderline personality disorder. They have completely chaotic lives. They have very high rates of self-harm and suicide. And if you look at the gene expression, they have methylated that gene and they're deficient in this essential protein. There's a form of psychotherapy called dialectical behavior therapy, which is curative in about 85% of patients. There's no relapse. And if you do, and these people now recover from this condition and they change the structure of their brains, and if you do the genetic analysis, you find that they are no longer methylating that gene. The gene is turned on, the brain growth factors come back. So our life stories and experiences are turning on our genetic expression, and it's another example of how suffering is causing disease. So how do we help the typically frail elderly patients with multiple comorbidities? How do we help our patients heal? And I think it's through compassion, and it's our humane response to suffering, and that is the primary role of us as carers, as physicians. And the time when our patients heal is when they transcend that suffering and find true happiness. And I want to explore that theme some more and what it means to health professionals. We often talk about the leading cause of injury or the leading cause of death, but how often do we talk about the leading cause of health? And I believe the leading cause of health in the USA is actually happiness. And happy people not only change their biology in really profound ways, but they also make healthy lifestyle choices. But we can be very nihilistic as physicians about trying to advise our patients to put in place lifestyle changes. It just never works. There's only one person you can change, and that's yourself. But what we know from experience, and many stories told us by people right around the world in the work we're doing in hearts and healthcare, is that health professionals who learn to find their own happiness and well-being, who heal themselves, and who practice with compassion make an amazing difference to their patients. And we have to be the change we want to see. We'll never lead our patients to health and well-being unless we find our own true happiness and healing. So here's some examples. A study of 20,000 insulin-dependent diabetics in Italy. They rated their primary care doctors as to their level of empathy. If you were a patient belonging to an empathetic doctor, you had 42% fewer admissions, emergency admissions to hospital for diabetic ketoacidosis. This is a study you've heard quoted already this morning. Access to compassionate palliative care not only hugely increased the quality of life and reduced costs, but led to a 50% increase in survival. This is a trial in an ER in the States of randomized access to compassionate care of homeless patients presenting to the ER. All patients had usual medical care. What was compassionate care? What was the intervention? It was the trained volunteers sitting with the patient and holding the hand and talking with them. That was the only difference in care, and it led to a 30% reduction in repeat presentations. This is one of my favorite studies. It's now 50 years old. If the anesthesiologist was supportive and gave some positive suggestion to the patient in the 5 minutes of the pre-op consultation, it halved the dose of opiate the patient required in the 5 days post-op, and it reduced the length of stay by nearly 3 days. This is a well-designed, randomized controlled trial. The only intervention is 5 minutes of a compassionate anesthesiologist. And by the way, this wasn't just the nice anesthesiologists and the grumpy ones. All the anesthesiologists had to role model this practice. Now, the annual expenditure in the world on statins, drugs to reduce cholesterol, is $29 billion a year. And yet Helen Rees and her group in a recent meta-analysis has showed that the quality of empathetic caring of the doctor has a larger effect size on reducing your 5-year risk of a heart attack or a stroke than putting a patient on a statin. Is this not a moment in history when we make a choice? But we have a major problem, which is burnout of health professionals. And if you have emotional exhaustion and depersonalization, you're not capable of sustaining compassionate caring anymore. And the experience of the patient actually becomes the experience of the doctor becomes the experience of the patient. And that's how it links to the theme of this session. How prevalent is in the USA? About 45% of physicians and 30 to 40% of nurses. So our first priority for a compassionate healthcare system must be the health and well-being and happiness of all of us who work within the system. So Meredith and I, my wife Meredith and I in Hearts and Healthcare, and Stephanie Barnett and Kim Maddox at Choosewell, we've been working in Louisville, the compassionate city, under the umbrella of the Charter for Compassion, working to connect healthcare into that work. And we have a radical idea that we just explored a few weeks ago, and that is in the city of Louisville, in that compassionate city, instead of all the competing health providers doing their own wellness programs, let's all work together to create a community-owned centre or institute for happiness and healthcare that would offer completely free programs to all who work in healthcare and actually in education as well. And we can teach people the simple practices of a happy life. And we know from the science of positivity that really small interventions can make a huge difference, that 20 hours of mindfulness training can take a physician from burnout to flourishing. And let's do this with a generous heart and ask all the institutions and all the individuals in the city of Louisville to give their expertise and knowledge and to share it freely, and ask all those who attend programs or retreats or courses not to be charged any money, but to make a donation if it was of use in their lives. And on October the 7th, we had a meeting of senior healthcare executives and the dean of the medical school and nursing school, and they made a shared commitment to creating a community-owned institution for this purpose. So let's make this a reality. And we've already started. We started to celebrate with a Compassion Fest, a festival to celebrate all that's great and happy and joyful in healthcare. And I'm writing a new book, which is going to be called Happiness in Healthcare, and we're going to give it away for free. And we're calling on all of you, if you know a happy doctor or nurse, or you're a happy doctor, nurse, or therapist, write me and share your secrets and your insight. And we're going to just tell the story in the book of what happens in Louisville and all the wonderful stories that we hear around the world and everything we learned in this conference. And there's a link for you. So thank you so much for listening.
Our next presenter is living testament to what Dr. Youngson just said, that stories are powerful interventions. Yesterday I had a first in my life. It was the first academic, scientific conference I've ever attended where someone got a spontaneous standing ovation, and that someone was Bridget Duffy, so I can't wait to see what she talks about today.
Thank you so much for having me back today. I shared with you yesterday that it was one patient that altered my career in medicine about 20 years ago. What I didn't tell you was the story behind that patient that I spent the night on call in the ICU with. But I'd gotten called, it was the last month of my residency from the ER, and they said, in Minnesota, it's November, and they said, we're admitting this patient, and I got a lot of calls like this in November. He's a 40-ish-year-old man who's fallen out of a tree stand. It's deer hunting season in Minnesota. And what you don't know about Minnesota is they're stoic Norwegian bachelor farmers, if you listen to Garrison Keillor on Prairie Home Companion, or Minnesota Nice. So they don't say too much. But when I got to his room, the ER doc said, I'm just going to admit him to the floor. You can admit him up on the unit, just a regular floor. So I walked into the room, and I took one look at him, and the first thing I saw was this absolute fear in his eyes. And I went through the history, and he still didn't say much. And at the very end, he looked at me, and he said, I think I'm going to die tonight. And I looked at all his numbers and all his data, as you heard about this morning. And then I looked at the nurse, and I said, let's transfer him to the ICU. And I walked out in the hall and she said, there's no reason to, all of his numbers are right, everything's, normal in the labs. And I said, I don't care, let's transfer him to the ICU. And we spent the night running a code on this gentleman through the night. But I was brought home to that story this morning listening to Lloyd and Abraham talk about there's so much big data out there, but really it's your intuition and your human connection and listening to the patient's story that really guides us, and that we have to build healthcare systems that do that. So when I got home that night is when I read the paper, and have been on a wild journey for the last 20 years, like my colleagues here, to try to rehumanize healthcare. And my journey happened to start with an engineer who thinks as an engineer as a whole, not as diseased and fragmented body parts. So it was that morning, sleep deprived, that I called up this gentleman who I just spent his 90th birthday with him in Hawaii, who stood up in front of the group. He invented the pacemaker and founded this little company called Medtronic. But the paper he wrote 20 years ago that I read in my sleep-deprived state was called How to Build the Most Healing Hospital in America. And I because of that cold call, we've been on a journey together. And that day before I hung up the phone, he said one thing to me. He said, Bridget, as you start your career as a doctor, remember that only 20% of healing is linked to the technology I helped invent, the pacemaker and other things. He said, you need to focus on the 80% as well. And I said, what is that? He said, it's three things. He said, first and most important, it's the human-to-human interaction and connection that you have with your patient. Number two, he said, it's the physical environment. We have to create environments that help people heal, provide food and nutrition and light in their rooms. And lastly, he said, and very importantly, is spirituality. We have to return spirituality back to healthcare and allow people to tap into whatever they need to heal. So after a few years, this hospital opens, and he wins the national award for the best food service and the best housekeeping in America. He beats out every hospital. So here is the two housekeepers who went and received this award on the wall. And when AHA flew there to try to understand why they won this, they interviewed the housekeepers, and they also interviewed the head of the food service. And what they found out is that every housekeeper had a business card that had their name on it and an identity. They were treated as an equal and valued member of the care team, and at the beginning of every shift, they walked in and said, is there anything I can do to improve your pain or ease your comfort? Not, can I clean your room? And they did the same at the end. And unbeknownst to anybody, over a third of the patients asked them, would you mind praying for me? I just got bad news. And they told nobody because they thought they weren't supposed to do that. It wasn't part of their job. And same with the head of the food service. She would gather her team in the morning and say, we're here to prepare food to help people heal. And if there's something not right in your life, go home and make it right before you come back and help prepare the food. So we've been on a crazy journey to try to accelerate the rehumanizing of medicine. But I did a little field work myself to help better understand what was broken in medicine. And this was a gift that my husband gave me for a significant birthday, as I'm aging here. Parked here at the Ferry Building in San Francisco, thinking it would be an easy way for me to get around. But about 17 miles later, this is the scooter that I ended up on. So what I'm here to tell you is what I learned as a patient, and it was mortifying. So here I am, the chief experience officer at a famous institution. My husband is the chief operating officer, and I break this leg here and fly in there, and my doctor says, show up at 7 a.m. and get an x-ray. So at 6:30 we show up, my husband pulls up in the car, and I limp out of the car, and the parking valet is there, and my husband says to him, do you have a wheelchair so my wife can get in to get an x-ray? He looks at his watch and he says, well, it's 6:45, my shift ends at 7 a.m. and I'm the only one here, so you'll have to go find one yourself. And I thought, wow, his shift might end a little bit before 7 a.m. today, once I get back to my office. But again, it wasn't his fault. I mean, he had no idea who we were, nor should he. The human experience shouldn't be about who you are in the healthcare system. So anyhow, what I found over those next few weeks is I would get into elevators as this anonymous patient on my scooter with my crutches, standing next to people in lab coats with a stethoscope around their neck, as you heard this morning, who would not hold the elevator or do anything for me, and go for blood draws and by rude and different people. It was amazing to be this secret shopper. Until one day, as I'm trying to get out the door, it's 7 o'clock, I'm leaving my work, and doors slamming in my face, and all of a sudden, this guy had come through the door, but he turns around and he walks 50 paces back and he opens the door for me. And I look at him in his construction uniform and his hard hat, and I said, "You are the first person in 2 weeks that has opened the door for me." And he looked down and he took off his helmet and he pointed to this button and he said, "Ma'am, the purpose of my job is to help people heal. I'm the construction foreman. I'm not just building buildings. I'm here to help people heal." And I said, "Can I run and get my camera and take a picture of you? We need to clone you in healthcare." So anyhow, people like Sam and another colleague have really gets me out of bed every day to keep going. This is a story I shared yesterday, a heart surgeon friend of mine who said, "Bridget, why don't you convene a group of doctors and nurses like the people in this room to define the standards for the nation and the world of what makes an ideal healing experience, not a hospital stay? Everyone today is judged on the length of stay and his core metrics." He said, "I'm not measured on what matters most to the patient." And he said, and most distressing, he said, "I'm going to send you something that was just sent to me, and this patient was on my service." So I hung up the phone, opened the email, and in it was question number 45 of a very long patient satisfaction survey of a 40-year-old woman who had open heart surgery. And the first thing she said was, "Terrible survey. You don't ask one question about the psychological harm you cause with your procedures. If you'd only gone to Google or Amazon, you'd find there's 20 books on depression with heart disease. And even though you saved my life and my heart's pumping, is that all you care about? What are you guys, just mechanics?" And he had underlined in red, "Are you just mechanics?" So because of his push, we have now, and my team have found over 50 physicians that have the title of Chief Experience Officer, hundreds of nurses that have already been doing this work, and leaders like Lloyd and Stanford and Jim, who have really helped us come around the table to go faster, to find innovations that restore humanity back to healthcare. These are some of the members of the group, and our charge when we met with Arnie Milstein at Stanford about 3 years ago at our first meeting was we said we cannot focus on the patient experience unless we also focus on the staff experience. And so our charter is not to just meet the triple aim, which you all know about, which is finding care innovations delivered at the highest quality, the lowest cost, in a patient-centered way, but our mission is to restore joy back to the practice of medicine. I meet too many doctors my age who want to quit or give up or go bake bread or do something else because of exhaustion. And our charter was to partner with people like you to find process and technology innovations that could become a checklist of always events to rehumanize healthcare. And these technologies or processes must reconnect people back to purpose. They also must optimize patients' and staff's well-being so that employees don't have to check their soul at the door when they come to work. And we have to improve communication. 12,000 complaints per year at the institution I worked. The number one bucket was communication. Never knew who my doctor was, never knew the plan of care, don't you specialists talk to each other. Next, we have to create a healing, compassionate culture where we treat each other that way and we treat our patients that way, so that our patients will have a consistent, seamless, compassionate experience of care. This is what I meet every day in the trenches. I'll ask nurses in 6 words or less, "Tell me what it's like to be a nurse in the trenches." They'll say, "Entered to care but lost my soul." And shame on us that we mandated by the government to have a disruptive physician policy. But we didn't enter medical school that way, as you heard this morning. This is Dr. Hojad's empathy survey. We entered, as you can see, quite high empathy scores, but over our career we drop down and we come back up nearing retirement. Does anyone know why the scores come back up besides retirement? Becoming a patient themselves or their loved one becomes a patient is usually what happens. He broke this down by gender. I'm sorry to the men in the audience, women had the higher empathy scores, and he broke it down by specialty. Emergency room doctors, family docs, palliative care, and I'm sorry to my surgical colleagues, your scores weren't so good. But it's not broken people, it's broken processes and bureaucratic systems. The whole nation is focused on the leanification or the stripping out of waste, which we need. We need to be efficient, but it's not enough to just be efficient. I shared this slide yesterday. This physician, this pediatrician, was mortified when his 7-year-old patient sent this crayon drawing, which showed her smiling on the table and his back to the wall typing on the computer. This is contributing to the fatigue that my colleague just shared with you and the 4,000 clicks this morning that Abraham Verghese shared. And a surgeon sent me this. This is one of his patients with a 20-day length of stay in his hospital before the EMR, the electronic medical record. And on the right is a patient of his with a shorter length of stay, and he called it meaningless use paperwork. This is causing fatigue of doctors, nurses, and patients, and it's breeding a level of cynicism like nothing I've seen. I'll meet doctors and nurses who will say, my administration wants me to work harder, faster, with less money, and now they want me to look up and smile and be nice to the patient. And, you know, I focus on the HCAHPS, or the patient satisfaction survey, and doctors will say to me, oh, you're that doctor with the happiness index. So we can't have a dialogue with our staff around just working smarter and faster and telling them what to say. So the key and the secret sauce is what we need to do to fix healthcare. And the key to the ideal healing experience is we have to do this piece about being efficient and safe and high quality. And lean is about taking out 7 types of waste. But what most people don't do is map the gaps in humanity or empathy and find the 7 things to put back in. And that's what restores healing to healthcare and creates an ideal healing experience. And that's what drives growth and loyalty in healthcare today. So the way to do that is very easy. We just have to build this into the operating infrastructure in the healthcare system in the United States, is we have to map the gaps in the first impression to the last, before people arrive in our doors, while they're there, and after they leave. And if we focus on the things that are around compassion and addressing their emotional needs and improving communication, we can solve most of the issues people are experiencing in healthcare today. So just in closing, I thought I'd share with you again a couple new Always events from yesterday, and a couple of the same ones from yesterday, just because I think they're fairly powerful. But I shared with you yesterday from a first impression to change the experience in the operating room of the orthopedic surgeon who stopped all the commotion and had everyone in the room come up and look the patient in the eye and tell them their name and that they were there to help them heal. I had a similar experience with an eye surgeon doing LASIK surgery on me at a prominent institution where I'm the last case of the day, and I'm walking in after all these famous baseball players are walking out, and they take me into this room, lay me on a table, put a thing on my head, and all this staff is standing around me. I've not been introduced, and I thought, oh no. I jump off the table, I looked each of them in the eye, I told them my name, that I was not LASIK surgery number 26 of the day. I said, have you eaten? Have you had anything to drink? Have you peed? You know, how are you today? So that I wouldn't just be the next eye case. So there's ways to humanize the experience during a surgical procedure. I talked yesterday about informed hope. Why, right before we put people to sleep, do we tell them everything that can go wrong? They can get an infection, bleed, even die. Please sign here. Because of one patient and one enlightened anesthesiologist, informed hope can become a new standard of care in healthcare today. I met a woman in Phoenix Friday from the UK who shared with me the story that her 18-year-old son had been on a kidney transplant list for 2 years, finally got the kidney on perfect match on Christmas Eve. And she said, we're all set to go, great bond with the surgeon. The anesthesiologist who they'd never met walked in and said, I need you to sign this consent form for a central line catheter. And the patient said, oh no, my surgeon's already agreed to use my port and peripheral catheters. I have huge issues with the central line. She said, you must sign this. He said, I refuse. This goes back and forth. And finally she says, all right, well, if you're about to die on the table, will you at least consent to it then? He says, well, I didn't think I'm going to die, but okay, I guess. Well, if your kidney starts to fail, would you consent? Well, I guess I would. At this point, the mother removes her from the room, talks to the surgeon comes in, chats with her son. The son looks the surgeon in the eyes and says, are there other people on the list that match this donor kidney? And he said, yes. He said, well, it's Christmas Eve. Somebody else is going to have a good Christmas. I'm not going to surgery with that anesthesiologist. And he gave up his kidney. This was last Friday I heard this story. He went on the following year to get his kidney, and he's doing quite fine, but she's trying to figure out what to do with that information and is on a mission in the UK, and I think she's going to partner with Robin. So I'm going to make that introduction since I just heard that story, but great opportunity to transform this experience. Should not happen today. Another quick one, since it was Veterans Day. There was a huge issue with the vets falling through the cracks with traumatic brain injury. The government, the president convened a task force to look at what we should do so this never happens to them again. And they called for hiring 150 health recovery guides in the United States. And the Wall Street Journal called them a bureaucratic Sherpa to help navigate the broken system. Every human being deserves a Sherpa on their journey. Last two, Code Lavender. I told you about this yesterday. Earl Bakken at his hospital in Hawaii. said to me, Bridget, can you ever launch Code Lavender at other institutions? His hospital, the code goes out on everybody's pager, Code Lavender room 309, everybody stops and sends healing, intention, or prayer to room 309. We've now adopted this at 10,000 places over the United States, are calling Code Lavender to resuscitate the emotional, spiritual, and physical well-being of doctors, nurses, and patients. This is a pharmacist who can tell every time a patient's been given a diagnosis of cancer. He takes the drug and walks behind the counter and sits down and walks them through the side effects. Random act of kindness. I shared with you yesterday, everyone knows how to track a pizza, but we take breast tissue or prostate tissue from a patient, and they live in fear of when the doctor will call and tell them that they have cancer or not. They know the date, the time, what they were wearing, as my brother did when he got the call, with no one next to him. There's no reason we can't ask patients, how would you like to receive difficult news, and who would you like to be by your side? Easy new standard of care. And building trust through technology. Technology can help us heal. This nurse audio recorded the discharge instructions. So great reduction in readmissions in healthcare today. So we owe patients journeys, not fragmented care, and it's my dream and my hope that there is technology that can enable your care team to help you heal and get them back to the bedside, and that we can actually have the healthcare system value the sacred and healing nature of the relationship and actually ease the burden of illness versus add to it. So thank you very much.
Heather Walker is going to talk to you about her work in the Dignity Health system, but what I think it's very important to know about her is that you know she must be a compassionate person because she was a pediatric nurse.
Thank you. I think it's true, being a pediatric nurse, it's a little bit more warm and fuzzy than maybe being an ED nurse, working in trauma, those kind of things. So I think I was lucky being a peds nurse, you get the warm and fuzzies. So I want you to take a minute and I want you to imagine that you had a conversation with a patient who had a bad experience in the hospital. When asked about that experience, the patient said the reason that they felt like it was a bad experience was because they didn't feel like they were treated compassionately by their healthcare team. Now I want you to take a minute to imagine that you could actually witness some of the interactions that that patient had with the healthcare providers. What do you think you might have seen that would have led to this conclusion from the patient? Well, it just so happens that I have some video.
Has your breathing been okay? Have you been struggling a little bit, or?
No, my breathing's fine.
It's fine. Okay.
Can you hand me a cigarette?
We can't smoke here.
Yeah, probably not the best thing to do right now.
Generally, it's
Unfortunately.
fine at this point. And if you're sick, we really don't want you smoking at all. Okay.
It's hospital policy as well. We can't allow you to smoke in here. So, unfortunately.
What am I supposed to do?
I think we just gotta tough it down for now. How does it? Are you okay with that?
We might be able to get you a nicotine
Spoken like
patch.
someone who's not a smoker.
This is true. I understand. I don't know, but I think it's just not really an option at this point.
What we could do is maybe
I know it's
homemade is like a nicotine patch, just to kind of settle if you're getting a little anxious, but we can't allow you to have an actual cigarette, unfortunately. Okay.
Okay.
Is that okay?
Okay.
But I do recommend maybe later. You know, it's never too late to think about maybe stopping smoking. Okay. I'm sure you get that a lot, but it's never too late.
Okay, so we're gonna go talk to the nurse, put some orders in, and adjust some of your medications.
Okay.
If you need anything from us at all, you can get a hold of us. Okay.
Okay.
Do you have any questions?
Uh-uh.
Okay, we'll be right back.
Okay.
We're gonna get something sorted out with the itching.
Okay, thank
So
you.
just, all right. Like I said, if you need us, you can just have to be a buzzer or something. I assume.
Okay.
Are you allergic to any medications?
We
Just the Keflex only? Okay.
Did you?
Are you okay? Are you okay? What's wrong? Are you hurting anywhere? Do you want to help me help her up? You just fell? Oh.
Yeah, I was trying to get my purse.
Okay, you good?
Ouch.
You okay? Anything hurt?
No.
You were trying to get to your purse? What did you do?
Oh, my lip bone.
Your lip bone?
Did you fall getting out of bed or when you stood up?
Getting out of bed.
Did you feel lightheaded before you fell?
No.
Can we make an agreement not to try and get out of bed?
Can we make an agreement that you give me a call light?
Oh, you don't have a call light?
You
Oh,
said
we'll
I was
definitely
supposed
get
to
you a
push
call
something,
light.
but I don't know what to push, so.
We could make an agreement to find you a call light, absolutely. Yeah.
Okay, then we have an agreement.
Okay.
So now imagine that immediately following this encounter with the healthcare providers, that the patient was willing to give feedback about what it felt like to be the patient. Specific feedback about areas that those healthcare providers could have provided a little bit more compassion. What do you think the patient might say? What do you think you would have said? Let's take a look.
I'm here to give you some feedback on what it felt like to be your patient. At one point, though, I think when we were talking about the itching and the possible allergic reaction, there was a conversation going on between you guys that I would have preferred to have been let in on, since you were discussing my situation as the patient. Does that make sense?
Absolutely.
Okay. About the smoking thing. I totally understand where you're going with that, and that you guys are all physicians and have people's health in mind, and smoking is not a good thing. But perhaps a better way to broach that subject with a patient, instead of saying, it's never too late to quit smoking, which A, made me feel old. B, perhaps a better way to go about that is just say, if you should choose to quit smoking, there are, avenues that we can help you with, or something along those lines, and leave it at that so it doesn't become a pushy thing. When you were going to leave the first time, I appreciated that you wanted me to stay in bed. I felt a little bit unimportant when you said, I'm sure there's some way for you to get hold of us. I would prefer that you go the extra mile and find out how I'm going to get hold of you. But I have to say, I thought you handled it really well, and I got a little snarky with you about the let's make a deal thing.
Oh, yeah. No, that's fine. You see, that's fair, yeah. I didn't...
You didn't know.
Yeah.
You didn't know.
I should have found out, so...
And I think that's kind of a lesson as you go, that there's going to be a lot of things that you don't know, and when you think of how you deal with people out in the world, even if it's like a retail situation, what do you want to hear? I don't know, or I'll find out for you.
Mm-hmm.
So obviously that's not a real patient. I wish it was a real patient and we were able to have that kind of ability to give feedback, but it wasn't. So what you just witnessed was a simulation with third-year medical students using a standardized patient. Now the objectives given to the students were to identify patient safety issues and correct them. Now, these students didn't actually achieve all of those objectives because they left the side rail down and the patient fell out of the bed. But it wasn't a bad thing for us, because our purpose for this simulation was to observe their ability to provide compassionate care. Now, what we know about patients is how they feel they were treated while in the hospital can greatly impact their overall opinion of their health care. They don't often understand the complexities of the medical care that may have saved their life, but they understand how they were made to feel while receiving that care. And the feeling part, or the compassion part, is what we as individuals connect with. Ironically, it's the doing part, or the technical part, that actually saves their lives. So our goal, our purpose in our simulation center is to help healthcare professionals develop the skill set to do both, provide high-quality care compassionately. So by providing the opportunity to practice compassionate care in a safe environment, healthcare professionals can identify areas that they need to improve upon when working with real patients. Now, just like technical skills, starting an IV over and over, learning how to do a procedure, a sterile technique, they also need to practice compassion skills. And the more that they practice those compassion skills, the more effective they'll be at helping patients have a positive experience. Now, you just saw the feedback portion of it. And although sometimes difficult, part of the process is having the standardized patient give feedback about what it really felt like to be the patient. Also, we do guided reflection with the faculty and feedback from the faculty. Now, if any of you have ever gotten feedback about how you made somebody feel, you know that can be really difficult. That's actually harder to get feedback from how you made somebody feel than it is to say, well, you didn't have proper sterile technique or you didn't do the procedure correctly. But it's this debrief session after the simulation is the most important part of the learning process, because it allows the healthcare professional to make sense of the experience in the context of a real situation. By evaluating and reflecting on their own, how they acted in the room with the patient and the interaction between the patient and themselves, they can make sense of this experience and they can apply this to their real practice. And that's what we're getting at in our simulation center. We want them to take that skill set that they learn, even if it's difficult. I'm sure for that student, hearing that he should have got her the call light was hard for him to hear. He really kind of started arguing. I didn't show it, but he got kind of in a little bit of an argument with her because he felt like he didn't know. And her point is, you needed to find out. So that can be really difficult sometimes for healthcare professionals to get that feedback. But it's really important to the learning process. So by reflecting on that, they're able to put that into practice. Now, there's a couple of things that I would have reflected with the students on that the standardized patient was very specific on as well. She wanted to be included in the conversations in the room about her health care. And I know as healthcare professionals, we often talk with each other in the room and the patient's sitting in the bed, and we don't include them in the conversation. She also wanted a call light. And I know it seems like such a small thing, but when you're vulnerable and you're in a bed and you don't know how to get a hold of someone, you need to have a call light to call them. And just giving that call light is just a small piece of showing compassion for that patient. And finally, and I think this was, in my opinion, was one of the bigger points of the video, was them really understanding what it must have felt like to be a smoker that suddenly wasn't able to have a cigarette. So the one guy's like, well, you're just going to have to tough it out, you know, and she was like, obviously you're not a smoker. But the other student offered her the nicotine patch, which I thought was a really compassionate thing to do for her because she was worried about what was going to happen. So for all of the healthcare professionals that go through our simulations, what we really want them to do is take what they learned about themselves back to the bedside and apply that so that they can provide a positive patient experience, and it gives them the skill set to be able to provide compassionate care. Thank you.
I'm so excited that our final presenter is Joan Forte Scott, because she brings explicitly into the conversation something that we often overlook in our rush to try to measure things, and that is that it is family members around the patient and the clinicians who also are experiencing the healthcare system and who are going to be caregivers after people leave whatever building they happen to be in. And so they need to be also carefully included and welcomed and greeted with compassion. Thank you for being here.
Thank you. First of all, I feel like after listening this morning, I should just start with ditto, and then I'll take it from there. It's just wonderful to see the synergy amongst all of us and all of our disciplines, and I'm very grateful to participate today. My disclaimer is I am not a researcher, but I have been a nurse for 33 years. I've learned a lot from all of you that are researchers, and I've learned a lot from my observations of patients and families. And part of the joy in my career is that I continue to talk to patients and families every day, and that's an amazing learning experience. So what I'd like to share with you today is some ideas, some thoughts about how we can create an environment in our hospitals and healthcare organizations that can help us practice compassion and be compassionate with each other as well. So unfortunately, as you all know, this was taken from a recent blog. This is how people feel when they come into our organizations, and I just highlight the red areas: feeling violated, disoriented, stressed, treated like clinical objects. That's today. With all of our efforts and all of our concern, we're not very successful. And they're telling us that this competency without compassion is not what they need. And here I quote my great colleague, Dr. Verghese, as well, and you'll see him later, but very intuitive. So what is it the patients and families want? We've been talking about that a lot today, but there's great research, great work that demonstrates that all they really want is this compassionate human interaction from us. And if we think we're delivering that, our public, our clients, our patients, our families say no, not yet, we're not there. And yet there's a growing body of evidence that shows not only does compassionate care provide what people want to be able to heal, but it actually has a clinical effect. Their clinical outcomes are better, quality is better, safety is enhanced. And I say to my clinical colleagues, if we knew about a new drug that cured cancer, would we ethically be able to say, yeah, but it takes more time and we don't have money to buy it and we have to learn new stuff to do it? We wouldn't be able to do that. Well, caring for people with compassion does the same things, and we don't have the option ethically not to do that. What is compassion? So first we look to folks that are not within healthcare. And here you see those words, a human connection. And look at the simplicity of the statement by the patient. We are so focused on doing to and for our patients instead of with them in a compassionate relationship. A doctor's observation, again, my good colleague, you notice in red, human interaction, connection with the patients. It's really what they're looking for. At Stanford, we say our mission is to heal humanity through science and compassion, one patient at a time. All right, so we have kind of big ideals, right? Healing humanity. But at least we've finally figured out that compassion is part of that. And in academic medical centers and our hospitals everywhere, it's really hard not to focus on that science. We're just beginning that shift. And here's a challenge. Our environments are really difficult environments, right? Again, the red letters here, deteriorate into humanized machines, little time to cultivate more than superficial relationships. This is taken from a JAMA article, and this doctor was quoted earlier today. This is Dr. Peabody again, in his remarks to the graduating class of Harvard Medical School in 1926. If it was like this in 1926, what is it like today for those of us in healthcare? There is a solution to this, and we've talked about it somewhat today. I think that solution is patient and family-centered care, relationship-based care, and we know from research, from documented data, big data, that it does all these things. We know that patients are more happy. There's a Kaiser in Northern California did communication training around compassionate communication, and their Press Ganey score went up 17%. Made that CFO very happy, I'm sure. We know that there is a direct correlation between the ability to provide care and caring behaviors and how nurses feel about their work. Growing evidence, as you'll hear later today, about how actually providing compassion to our patients and families is the best way to take care of ourselves. I mentioned these health outcomes, a 19% increase in patients' compliance to their treatment plan when they're treated with compassion, and they're cared for in a way that builds relationship with those that provide their clinical care. Their adherence to treatment, but also pain control, their anxiety, all the things that come with being a patient when you're frightened and sick are better managed. Quality of life improves not only at the end of care, but for cancer patients, for pediatric patients, for geriatric patients, for primary care patients. It's been shown again and again. And guess what? Finally, the right thing to do for the people among us is the right thing to do for the business. Our costs of caring for people go down when we care for them this way. We do less interventions. Our costs for treating go down. We see less readmissions. We see better outcomes. So what is this thing, patient and family-centered care? And again, just look at those red words. Again, we see these concepts, mutually beneficial partnerships. And I want to really highlight that word mutually beneficial. I think sometimes in healthcare we think that patient and family-centered care mean we're all going to be like Nordstrom's and whatever the patient says is right, and we become personal servants or doormats. It's not about that. It's about respecting all the people in the environment and valuing them. It's about our relationships. Again, this hospital environment is so hard, right? You know, we are suffering ourselves, as you saw earlier colleagues present, you know, lots of symptoms of burnout. And the barriers, we say there's financial constraints here. First of all, how can we do one more thing, right? We don't have the time. Well, there's a great study out right now that shows in a clinic setting that physicians who demonstrate compassion and compassionate communication, actually their clinic visits are shorter than those who don't. And do you know why? Because we are wired to seek connection. And when we don't get it, and we're scared and sick, we keep trying. We ask questions after questions. We try to keep that physician or that caretaker in the room until we sense some compassion. But when we feel that initially, When we feel that from the moment we have that conversation, we can relax and we don't try to keep that person in the room. Financial constraints, how programs are built. The program at Stanford, we have 112 patient and family partners embedded in our work, 15 patient and family advisory councils, a speakers bureau, a peer-to-peer program, less than $300,000 a year. And my job is the only job that supports that currently, and that's a piece of an FTE. People will do this work because it matters, whether you're a clinical professional, a patient, or a family member in the community. When we come together to try to make care more compassionate, we do it because we care. So here's some thoughts. I think building compassion into our organization happens on two levels. The first one is creating infrastructures and places in the environment where we can really foster it. And the most powerful thing I have to say to you is create opportunity for patients and families and professional caregivers, physicians, nurses, respiratory therapists, social workers to come together outside of that care setting and talk about what's happening. Have dialogue. The most powerful thing to change behavior is the patient stories. You've heard many today. And that changes the way people see their care. It reminds us. Somehow we walk into hospitals, and even though we're patients ourselves, somehow we forget that when we come into work. It's just amazing. And we need to be reminded. We need them at our sides all the time. We need to have them involved in their actual care. We need to hear their voices. That bottom picture, can you imagine how that little girl feels with those people standing around with those masks? It's how our adults feel too. Our partnership model at Stanford acknowledges that each of the partners in this partnership has their own worries, their own world that we don't share with one another, but there's a sweet spot in the middle where we can converse. We have created layers of engagement, starting with Press-Ganey on the outside ring, all the way up to people in the platinum ring who are actually paid as patients and family members to help us with the work on a full-time basis. So people in our community can contribute at whatever level they're able. We have a program called the Same Day Feedback Program where we use Carolina as an example, a 2-time heart transplant, to visit other patients, to talk to them about their care, and to do something to intervene if there's something that's not working for them, and to bring us back information. Then there's the practice of compassion as individuals. It doesn't just happen because we want to be compassionate. We have to be intentional, we have to be focused, we have to be authentically present. And I would suggest to you a practice that Denver Children's uses, and that is something they call ritual hand washing. We talked about rituals earlier today. They ask their providers when they're washing their hands to wash their minds and spirits at the same time, to let go of that last conversation with their colleague, with another patient, to clean their mind and prepare to walk in and be fully present with that next patient. It's a wonderful ritual that has huge impact for a very simple thing. Don't underestimate those simple things. I told the story this morning of a woman who I talked to yesterday who talked about having ovarian cancer and having to have laparoscopy and waking up to see that where the little patches of gauze were, where she had been punctured, someone had cut the gauze into heart shapes. And what a difference that made for her to wake up and see little hearts on her belly instead of sterile gauze. We need our patients and families in partnership with us. They bring a perspective we don't have. We've tried to heal ourselves. We've tried to cure healthcare by ourselves. We can't do it. So my challenge to all of you is to bring them to the table, bring them inside your organizations, listen to their perspectives. The patient and family have different perspectives, both equally important. And in healing them, we will actually heal ourselves. Thank you very much.
Well, I'm very sad to say that we have no time for questions and answers right now, but we do have a 15-minute break right now, so if you have some individual questions for our panelists, I'm sure they would love to visit with you. And we'll see you back in 15 minutes.